Hi, everyone. Thank you so much for joining us this evening for our monthly Building Bridges to the Community lecture series. For anybody that doesn't know me, I am Rachel Narwald. I'm the senior nurse practitioner in preventive cardiology working with Dr. Eugenia Gianos. And we are so fortunate tonight to have Dr. Dimitriy Nevelev joining us. He is the Associate Director for Outpatient Cardiology at Staten Island University Hospital and an assistant professor as well at the Hofstra School of Medicine. So he's going to be discussing heart disease in men tonight and hitting a lot of really pertinent topics. And I know there'll probably be lots of questions and lots of discussion. So please, everyone, feel free. Since this is a webinar, I know that you won't be able to speak to us, but put any questions you have in the Q&A section at any time. And then when Dr. Nevelev is done with this talk at the end, I'll make sure to pose those questions to him. So thank you so much again, Dr. Nevelev, for joining, and take it away.
All right. Well, thanks for having me. I'm very excited to be here. And so I'll be covering a topic today titled Heart Disease in Men, which really, to kind of give you a preface, really heart disease in men is much similar to heart disease in women with a couple of caveats. And so a lot of my discussion today will focus on overall prevention of heart disease, and then we'll kind of tail towards the end towards discussing more men-specific features. So the objectives of our talk today, so we'll begin first by defining what it means to have heart disease. We'll go on to talking about the traditional risk factors for heart disease for both men and women, and then towards the end we'll discuss sex-specific risk factors for heart disease in men, including the role of testosterone replacement therapy, and then the importance of erectile dysfunction. And so we know that heart disease is very common. It's the leading cause of death worldwide and in the United States. About 1 in every 4 deaths are from heart disease, with about 400,000 people dying annually as a result. About 1 in 3 men between the ages of 45 to 75 will already have a heart disease diagnosis, and then 800,000 people have a heart attack every year. So that's 1 every 40 seconds, with an average age of onset for 65 for men and 72 years old for women. I like to discuss heart disease in 4 specific segments. And so the first is the structure and function of the heart muscle itself and the different aspects within the heart structure. First, we think about heart failure, which can be a weakness of the heart muscle, so the pump is not able to get enough blood flowing to the rest of the body. We can have heart valve disease, which is when the heart valves are either too tight or too leaky. And then we can have diseases that affect the muscle of the heart, such as hypertrophic cardiomyopathy or other systemic illnesses that actually just affect the actual fibers of the muscle itself. Next, I like to think about the coronary arteries, coronary from the Latin term corona or crown, and I like to refer to this as the plumbing. And so because the heart is a muscle, it requires its own source of energy, oxygen, nutrients, and the way that it gets that is by the 3 main arteries that sit right on top of the heart muscle. So over time, for many reasons, be it genetic, lifestyle, there's a tendency to develop plaque within the arteries of the heart. And so looking at that bottom image on the leftmost segment, you can see a normal artery in cross-section where there's just a protective layer on the inside that keeps essentially the cholesterol out of the inner layers. And then there's a muscular layer within the middle, which allows the arteries to get bigger and to get smaller as needed to meet the heart's needs. So over time, plaque can start building up, which is when cholesterol breaks through that protective barrier or endothelium and starts layering underneath. And if it gets to a critical point where blood is restricted and can't pass through that narrowing, that's when we start to experience symptoms of what we call angina. It can be chest pain, shortness of breath, or any other symptoms that are related essentially to a decrease in blood flow. And then, of course, as it keeps growing, it actually grows similar to a pimple, where it gets to a point where it's unstable and that plaque can burst. And that's essentially what leads to heart attacks, when the plaque becomes unstable and causes a sudden, full 100% blockage of the blood clot that forms afterwards. And so that's part 2. Next, we have the heart rhythm. And so the heart has top chambers and bottom chambers, with the top chamber squeezing first and the bottom chamber squeezing second. And that's all orchestrated by the electric system as illustrated here on the right. And so we can have rhythms like atrial fibrillation, which is quite common, where instead of having this neat pathway directly from one point to the next, there are hundreds of different points in the top chamber that start to get excited at the same time, and that causes people to have erratic heart rhythms that then increase their risk for stroke. And then, of course, we can have heart rhythms that are too slow or other heart rhythms that are too fast. This generally illustrates the point. And then lastly, we think about the circulation outside of the heart. So the heart pumps, and all that blood has to go somewhere, and it goes through the aorta, which is like the superhighway of the body. And so the aorta has branches, which then go on to feed the brain via the carotid arteries, that feed the arms, the arteries that feed the legs, the kidneys. Every nook and cranny of our body is covered in an artery system, and it gets delivered essentially through that aorta. And so it's important to make sure that if there is any disease in the heart, is there also disease outside of the heart? And that's a critical portion of what we do in cardiology. So how do we prevent heart disease? Well, we break it down to 3 different segments. At the very bottom, we have what's called primordial prevention, which is addressing the factors that cause the risk factors to actually develop. So thinking about things that are modifiable, smoking, being more physically active, eating a better diet, because these are all factors that can impact development of risk factors like high blood pressure, high cholesterol, and diabetes. And so primary prevention is once somebody already has these diagnoses, so for example, if somebody already has high blood pressure, making sure that that doesn't lead to the development of heart disease. And then lastly, secondary and tertiary prevention is what we think about when somebody already has heart disease, be it a heart attack, stroke, plaque, and trying to prevent them from having either a second event or if they haven't had an event but they're high risk, trying to prevent them from having their first event. And so the American Heart Association makes it easy. They put what's called the Life Essential 8 online, where everyone can reference this. And there's 8 key factors that I'll dive into that help prevent you from developing heart disease to begin with. And so first we'll talk about high blood pressure. So the target blood pressure is to be less than 120/80. In elevated blood pressure, which doesn't quite meet the diagnosis of hypertension, is 120/130 on top, less than 80 on the bottom. Stage 1 hypertension is having a blood pressure above 130, but below 139, or above 80 or less than 90 on the bottom. And then stage 2 hypertension is having an average blood pressure of greater than 140 or greater than 90. It's important to recognize that it's either or. So if your blood pressure, for example, is 115/90, technically already have stage 2 hypertension. And why do we care about hypertension? Well, simply because it's very directly correlated with incidence of heart disease, including heart attack and stroke. And so looking at the left-hand side, this looks at systolic blood pressure, the number on top, and how it increases risk of heart disease relative to how high it is. And so the lines going from top to bottom go over the different ages. So the top line is ages 80 to 89, the bottom line is 40 to 49. And so what this illustrates is that regardless of how old you are, every 20 millimeter mercury increase in the top number doubles your risk of having heart disease. And similarly, for the bottom number on the right-hand side, every 10-point increase in blood pressure, regardless of how old you are, doubles your risk of having heart disease. So it's never too soon to pay attention to blood pressure, and the lower the better. And it's important to highlight how to measure blood pressure correctly. In fact, it's hard to do, and in the office, we often have a hard time doing it as well. First, of course, you have to be seated comfortably in a chair that has back support. You have to have your feet flat on the ground and not crossed. You want to be wearing an appropriate sized cuff, so if it's too large or too small, that'll significantly affect the readings. And then there's a couple of factors that aren't often talked about. So for example, having a full bladder can add anywhere up to 15 millimeters of mercury on the top number. If you're talking while the blood pressure is being measured, that can add 15 millimeters of mercury. Measuring over clothing can overestimate by up to 50 millimeters of mercury. And then you have to be sure that you're not using any stimulants before your blood pressure is measured. So that includes nicotine if you're smoking, alcohol use, or caffeine. And we often start medications, but sometimes I like to refer to the medications as bridges, meaning we start them to protect you, lower your risk of having a heart attack or stroke, but also we work on the risk factors that got us to having high blood pressure to begin with. And so in terms of the things that you can do outside of just taking medicine, being more physically active has a dramatic impact. Conforming to a healthy diet like the DASH diet can reduce your blood pressure significantly. Reducing sodium intake, especially as we get older, salt intake plays a very significant role in the regulation of our blood pressure, and then limiting the amount of alcohol we consume. So medication is important, but don't forget that you also have to focus on what got you to having high blood pressure to begin with. Next, we talk about cholesterol. And so broadly speaking, for somebody who's never had an event, we want your cholesterol in the form of LDL to be less than 100, or in the form of ApoB, which isn't commonly measured, but is becoming a little bit more prevalent, to be less than 110. If you already have a history of heart attack, stroke, or disease in the arteries of the legs, you want that LDL number to be less than 70. And if you're particularly high risk, if you've had multiple heart attacks, multiple strokes, multiple areas of your body have plaque buildup, we even recommend being very strict with the LDL to a level of less than 55. And the reason for that is simple. You know that the more cholesterol you have in your bloodstream, the more probability that it's going to layer in your arteries and develop plaque. And so this was a very nice study that they did in young people. So I believe the average population here was, I believe, in the 40s. And they followed them over time to see what was the risk of having plaque in different arteries, depending on what their level of LDL is. So they looked at the arteries in the neck, the carotids, they looked at the arteries in the legs, they checked the calcium scores in the arteries of the heart. And essentially, the higher the LDL, the more likely you were to have arteries that were affected by plaque buildup. And for the patients who had LDLs in the 50 to 60 range, there was virtually no plaque, compared to the 150 to 160, where about 60% of patients already had plaque in at least one artery site. And it's not just the extent of cholesterol, so it's not just having 160 versus having 120. It's also about the duration of being exposed to that high cholesterol number. And so somebody who's born with high cholesterol, with a diagnosis of what we call familial hypercholesterolemia, they tend to develop heart disease at a much younger age because their arteries are, so to speak, marinated in a high cholesterol environment for a longer period of time. And so they'll see onset of heart disease at a much younger age. Now, compare that to the yellow marker here, which shows modest hypercholesterolemia from adulthood. They'll have a slightly more delayed onset of disease, but then compare that to the green one, which shows lifelong low LDL control, which shows potentially avoiding having a diagnosis of heart disease to begin with. So the earlier that you treat your cholesterol, the lower the number, the less likely you are to develop heart disease long term. And just a brief word about one of the newer things that we've been measuring over the past few years, something called lipoprotein A. And so, of course, what we do in life affects our cholesterol numbers, be it diet, exercise, et cetera. But lipoprotein A is a little bit special in that our lifestyles don't significantly affect this number. In fact, about 80% of someone's lipoprotein A number is predetermined by genetics. This value tends to stay relatively stable. So people who have high levels of lipoprotein A, they don't see significant variability changes in their lifestyle. We know that there is significant variability between ethnicities, with Asians having less than Caucasians, and Caucasians on average having less than Black patients. And we know that there's a strong correlation, and this is why we're so concerned about it. We know there's a strong correlation with both development of plaque in the arteries of the heart, as well as thrombosis or development of blood clots. And so patients who have high lipoprotein A tend to develop coronary disease at an earlier age, aortic stenosis or tightness of the aortic valve, stroke, and atrial fibrillation. And most guidelines at this point recommend having this value checked at least once in your life to see if you carry a high risk. Diabetes is relatively straightforward, and so normal is having an A1C value of less than 5.7. Prediabetes is defined as 5.7 to 6.4, and diabetes is above 6.5. If someone is diagnosed with diabetes, the goal for most patients is to have an A1C of less than 7%. The diabetes, of course, is becoming much more common. About 10% of the world will have diabetes by 2035. And we care about this from a cardiac perspective for many reasons, but really it's because diabetics tend to have earlier onset of heart disease, much younger age. When they do have heart disease, it tends to progress much faster, and they tend to have much more complications. And more importantly, a lot of diabetics actually have less symptoms of heart disease. It's possible to have silent angina or silent ischemia, and that can be a big impedance to getting a early diagnosis. And prediabetes is actually more important than we thought. And so looking at this study at a young population, about 45 years old on average, having an A1C already above 5.5, which is technically within the normal range, is already predictive of developing plaque in the arteries of our heart. And so you can see just on the graph over here, 5.5 is kind of the breakaway point, and then with increasing levels of A1C, the probability of having plaque in the arteries continues to increase. Obesity is a very common topic these days, especially with the release of the GLP-1 medications. And so when we talk about obesity, we really think about the BMI. Bit of an imperfect measure. It's essentially trying to see height compared to weight and trying to put you in a category. It's imperfect because if somebody is muscular and they have a different body composition, they may technically, by this metric, have obesity. So you have to look at this number with a bit of a grain of salt. But generally speaking, we consider a normal BMI of 20 to 24.9. Overweight is 25 to about 30, and then obesity is considered any number above 30. From a cardiac perspective, we really care about obesity, at least in my eyes, for two different reasons. First is that people who have obesity, they tend to have more metabolic risk factors. They tend to have a higher risk of having high cholesterol, having diabetes, having high blood pressure. So they are much more increased risk of developing the disease. Now, the second thing that we get concerned about is patients who have obesity, they tend to be less active. And then over time, because of their obesity, they tend to develop higher risk of developing osteoarthritis, particularly of the knees and the hips. That, again, makes them less likely to be physically active. And it kind of works as this kind of loop where patients become less active, they have worsening of their metabolic illness, they tend to kind of spiral. And so it's incredibly important early on to address obesity. From a cardiology point of view, we really became more involved with the management of obesity with the release of this trial that came out last year called the SELECT trial. And so this looked at a higher risk population, patients who already had heart attacks, who already had strokes, or who had disease in the arteries of the legs. And then they randomized them to receiving a medication called semaglutide. And so patients would inject themselves once a week, and then they would follow them over a 48-month period to see whether or not they had an increased risk of cardiac events or whether or not they, in fact, had a decreased risk. And the study was very convincing. There was a 20% reduction in the risk of cardiac events at the 48-month period. And so now this has become part of our armamentarium that we are much more frequently using. Now, heart-healthy diets, it's a bit of a tricky discussion, but I like to try to simplify it to make it more understandable. The three recommended diets by the American Heart Association are mainly the Mediterranean diet, the DASH diet, and the plant-based diet. Now, instead of labeling the diet, I do like to kind of go over generally what comprises a good diet. And so the first thing I always mention is high fiber. We definitely don't get enough fiber in our diets, and so this is very important for everyone to focus on. High fiber foods will include vegetables, fruits, beans, lentils, whole grains. This is important for many reasons, but among them is that one, it helps control your cholesterol levels, but second, it also really modifies our gut bacteria. So we all have bacteria in our intestines, and having more of the, so to speak, good bacteria overall reduces inflammation and can have a profound effect on risk of heart disease. And so high fiber definitely helps promote that. The second thing that I talk about is trying to focus on good quality fats. So the omega-3s are the ones that we always speak to. And so that's going to be found in fatty fish like salmon, tuna. If you're a more adventurous fish eater, then mackerel, sardines, anchovies are definitely high omega-3 sources. Walnuts are an excellent source, chia seeds and flax seeds if you want to just put them in yogurt or smoothies or oatmeal, definitely a good way to get omega-3s in. And then extra virgin olive oil is a commonly cited one. Next, we want to minimize processed or ultra-processed foods. So that includes the white breads that you find commonly at the grocery store. Ready meals, so things that are easily microwavable, disposable. Cakes, chips, sodas, junk food, so to speak. And lastly, you want to avoid excess caloric intake. So really, this is why the Mediterranean diet kind of strives. If you look here at this outline of a Mediterranean diet, it primarily focuses on getting protein in the source of fish and seafood, or the focus on getting vegetables daily, fruits daily, legumes, whole grains, olive oil. It does allow for red meat up to once a week, white meat up to twice a week. You can have eggs. You even have white wine up to a glass a day for women or up to 2 glasses a day for men. And then, of course, it tells you to avoid processed meats, sweets, refined carbs, sugary beverages, etc. And we do have good data to support the Mediterranean diet. The PREDIMED study which was updated and republished back in 2018, did show that there was a significant reduction in risk of heart attack, stroke, and death in patients who were on a Mediterranean diet compared to a control diet, which was a low-fat diet. So certainly, it's not just that we have the idea that it's better, but we have concrete evidence that this does help reduce risk of heart disease. Many other diets do not. And then what about plant-based diets? Really, it depends on what you call plant-based. And so the two images we have on the left, they both share the same concept in that they are both plant-based. Oreos are considered a plant-based food. And so studies looking into plant-based diets have looked at the difference in what kind of plant-based food people are consuming. And so on the right-hand side, that kind of red-orange line, that looks at adherence with a healthy plant-based diet and risk for cardiac disease. So as you can see, the more you are adherent to this diet, the lower the risk of heart disease. And then that dotted line in gray on top looks at patients who are more adherent with an unhealthy plant-based diet, so eating more of the chips and the Oreos and the other foods. And they, of course, had an increased risk for heart disease with increased adherence. And so it definitely matters what kind of food you're consuming. And then lastly, about diet, I do like to point out that low-carb and very low-carb diets are very common these days. A lot of patients come asking questions about whether or not it's safe. So as a word of caution, from the cardiac perspective, what we know is that it does increase the bad, so to speak, bad cholesterol, the LDL cholesterol. And we know that in general, low-carb diets cause an increased risk of cardiac events. The trouble there is some of the studies that are done, they don't really specify whether the diet is a ketogenic diet or just a low-carb diet. So it's tough to parse out exactly what about it besides the LDL rise causing this to happen. But definitely we're seeing a trend towards higher risk with this diet. One caveat here that I'd point out is that when patients adhere to low-carb diets, it's not just that they have an increase in their LDL. It really matters about their genetic background. So this study here on the right side, it looked to see if somebody has a genetic predisposition towards having high cholesterol, and being on a very low-carb diet will significantly cause them to have an increased cholesterol level. And so to make it simple, the bottom line is if you're going to be using a low-carb diet, you have to follow your LDL to make sure that it doesn't significantly increase. And then if you have already a known or suspected genetic cholesterol abnormality, you should generally avoid being on a low-carb diet. Next, we talk about physical activity. And so the guidelines are to have 150 minutes of moderate intensity activity. So that means walking with your arms swinging at the very least, or 75 minutes of high intensity activities. So biking, running, swimming, something that really gets your heart pumping. And this is really important because one, exercise has a control over a lot of the risk factors. So exercise has improved blood pressure control, decreased sugar, decreased cholesterol, but modestly so. It improves the endothelial function, meaning that it improves the function of our lining of the arteries. It improves autonomic function, which means it helps us regulate our blood pressure and heart rate better. And then it decreases stress and improves mood, which then has many upstream effects. We do like to talk about what's called cardiorespiratory fitness, which is our maximal ability to exert ourselves. And there's generally two ways to measure them. One is through maximal oxygen consumption, which is a test that we do in the lab. And the second is via something just called monitoring your METs, or metabolic equivalents. So the chart on the right shows for moderate activity exercises how many metabolic equivalents are there. And so the higher the number, the more vigorous of an activity. There in light gardening at a 2.3, we see that walking at 4 miles per hour puts you at the 5 range and so forth. It's really critical because we know that for each 1 MET improvement in your cardiorespiratory fitness, there's a 15% reduction in cardiovascular events. So we have to really be on top of this. And we do have pretty strong data to support that the more physically active you are, the lower the risk of dying. And so on the left-hand side, this is a chart comparing people who were categorized as either low performance, below average, high, or elite. And of course, there's a linear kind of progression there, where the more physically fit you are, the less likely you are to die. And I like to use this graph on the left, because it really shows that you don't have to be an athlete to get significant benefit. Even if you go from the low to the below average category, there's already a 50% reduction in risk. And so that's the right-hand side, we had a very elegant study that showed that even just walking a couple of thousand steps already decreases your risk for cardiovascular death. The more you walk, the lower the risk, but it really only takes a couple of thousand steps just to get the process going. And so even if you're able to just muster walking around the block a couple of times a day, that's going to be a lot better than sitting at home and doing nothing. Tobacco use is quite simple. You want to avoid starting smoking, and if you are a smoker, cutting smoking is the #1 thing you can do really to decrease your risk of heart disease. In fact, we see that at the 3 to 6 year mark after stopping smoking, there's already a 50% reduction in risk of MI. And so other than being physically active, there really isn't much that we can do from the cardiac perspective to tell you that we're going to decrease your risk by half. There's really no medicine out there, nothing else that I can give you. I can tell you in 3 to 6 years, your risk is significantly down. Now, for the other factors, so lung cancer and colon cancer and emphysema, it takes a much longer time to see that significant drop in risk. At about 15 years, we do see that patients' coronary risk goes back to baseline as if they never smoked. And then more recently, we're finding that unfortunately, even smoking a cigarette a day carries a significant risk. And so studies show that patients who smoke 20 cigarettes a day compared to patients who smoke 1 cigarette a day have a reduction in only 50% in their risk. You would suspect that if you cut from 20 cigarettes to 1, that you cut your risk of heart attack by 95%. But the truth is, it's not there. It's really at 50. So absolute smoking cessation is the recommendation. No cigarettes at all. And then sleep duration and quality, often ignored, but something that is incredibly important. So we want people to get 7 to 9 hours of sleep, and we want people to recognize and treat sleep apnea. So in terms of sleep duration, people who sleep less than 5 hours a night have significantly increased risk of heart disease. In fact, it's 2 to 3-fold, and this is both in young populations and older populations. If we're thinking about reduction of risk of heart disease, every hour that you gain on average is going to be the equivalent of dropping your blood pressure by 16 points, meaning that your risk reduction from having a drop in blood pressure is equivalent to your risk reduction of sleeping more. Now, there's some interesting data, especially about daylight savings, which I just wanted to point out more as a curiosity. We do see that the rate of having stents placed increases the Monday following daylight savings. In fact, there's a 24% increase in the risk of having a stent placed. And then the question is, why does this all happen? Well, we know that people who get poor quality sleep or decreased sleep, they have increase in their sympathetic drive. They have a rise in cortisol levels, or that's the rise in the stress hormone. They have higher blood pressure, and they're more likely to retain salt, all of which then leads to an increase in the risk of heart disease. And then as a second note, people who don't sleep as well, they tend to have more poor dietary choices, and because they're not sleeping as well, they have less energy, and so they're less likely to be active, all of which drives more heart disease. Sleep apnea is very common and very under-recognized. So it's defined as having repetitive cycles of apnea or not breathing, which then leads to inflammation and then leads to dysfunction of the endothelium and the lining of the arteries. And so when we're sleeping, if somebody has obesity, the actual weight of their neck can actually push on their breathing pipe and decrease the amount of oxygen that's getting to their lungs. Other people can have large tonsils, large adenoids, and things that just block the backs of their mouths that also can cause them to have sleep apnea without having obesity. And so regarding sleep apnea, we know that patients who have high blood pressure have a high prevalence. So 1 in 3 patients who are diagnosed with high blood pressure also have a concurrent diagnosis of sleep apnea. The patients who have sleep apnea are very likely to develop arrhythmia, with 1 in 3 sleep apnea patients going on to develop atrial fibrillation. And then patients with sleep apnea are also at increased risk of heart failure and, of course, coronary disease. How effective is the treatment for sleep apnea? This is where it gets a little bit tricky. So we know that there's significant improvement for sleep quality, for daytime sleepiness, for quality of life metrics. People feel like they're kind of sharper, their measures of cognition go up, and we do see a small reduction in blood pressure, about 5 points on that top number. Short-term studies don't show significant reduction in cardiac event rates, so this isn't what we would say is a big factor in reducing your risk of heart disease. But it could just be that short-term is not the right period of time to study. This could be a matter of years and years of adherence to CPAP therapy to really decrease your risk. I don't know yet. And then hot off the presses, I hate to keep bringing it up, but the GLP-1 agonists, they are now being studied for use in sleep apnea. And so just published a couple of days ago in the New England Journal of Medicine, we saw that obese patients who had moderate to severe sleep apnea, whether they were on CPAP or not, significant reductions in their sleep apnea index, which had less sleep apnea, a significant reduction in body weight, as we would expect, decrease in their inflammatory markers, and a significant improvement in their blood pressure. So it's not something that's approved for this indication at this time, but certainly it's possible that within the near future, this could become one of the ways that we treat sleep apnea. Moving on to the last portion here, I wanted to talk about the male-specific considerations for heart disease. And so again, before I started the lecture, I mentioned that really the risk factors for developing heart disease are mostly shared regardless of gender. Having good control over your cholesterol, your blood pressure, your sugar levels, et cetera. But there are a couple of sex-specific considerations. And so starting out, I wanted to talk about low testosterone. So as we age, our testosterone levels as men naturally decline about the age of 40, sometimes a little bit younger. Patients who have low testosterone levels tend to have symptoms of deficiency. That could be decreased libido, erectile dysfunction, fatigue, mood, irritability, and an increase fat to muscle ratio. Not everybody who has low testosterone will have these symptoms, and so it's important to kind of make that distinction. Risk factors for developing low testosterone include obesity, diabetes, diagnosis of heart failure, COPD, and chronic opioid use. So patients with chronic pain that require use of opioids, we commonly see that the testosterone levels run low. We know that lower levels of testosterone are associated with increased all-cause mortality, which is to say people any reason for death is associated, and it's also associated with an increased cardiovascular risk for heart. And so what are the typical labs that we order when we check testosterone? So first, it's a morning lab, so it has to be drawn in the morning. We can look at total testosterone, which is a measure of the free testosterone, which is just testosterone that's floating around in the bloodstream on its own, which happens to be the active form of testosterone, the one that has the most clinical effects. And that also includes the forms of testosterone that are bound. So about half of our testosterone is bound to albumin, which is pretty readily available for use if necessary. It can unbind and the testosterone can be released. And then we have something called sex hormone binding globulin, which binds testosterone a bit more strongly, and that's not ready for immediate use. So when we measure total testosterone, it's all three of those, and typically about 1 to 3% of that number will end up being free testosterone. Free testosterone can be measured on its own. Typically, we want it to be between 66 and 309 picograms per deciliter. And then sometimes people measure what's called bioavailable testosterone. This is a combination of the free testosterone and then that albumin-bound testosterone. That's a measure of how much testosterone is more readily available for use in clinical effects. From the cardiac standpoint, back in 2010, it made a lot of headlines after this 2010 New England Journal of Medicine study, which looked at patients who were considered high cardiovascular risk, who were older, who had poor mobility, to see if giving them testosterone replacement therapy would lead to improved outcomes compared to placebo. And the trial was terminated early because they saw that patients who were on testosterone replacement therapy had an increase in the risk of cardiac events. So from there, the FDA initiated this review of testosterone product safety for cardiac disease. But it really had a couple of quirks in the study. And so their definition of cardiovascular events included some outcomes that we consider kind of low risk, such as having leg swelling or palpitations, people having syncope or passing out, not so much hard data like having heart attack or stroke. And so, of course, that did happen, but there was a lot of fuzz, so to speak, because of how they defined having a significant. Now, bring it to last year, there was another study published in the New England Journal that looked at 5,000 men between the ages of 45 and 80 who already had cardiac disease or were considered at high risk for cardiac disease, and they randomized them to getting testosterone gel versus placebo gel. So over the course of 5 years, they saw there was no significant change in the risk of death from cardiovascular disease, heart attack, or stroke. And so that is to say that the use of replacement therapy appears to be safe in this population. One caveat, of course, is that patients who were on testosterone replacement therapy did have increased risk of pulmonary embolism, acute kidney injury, and atrial fibrillation. And these weren't significant, massive increases in risk. It's certainly something just to keep track of and be mindful of if you're going to be using these therapies. And so what are some other considerations for low testosterone? Replacing testosterone, and the benefits associated will regress once you stop. And so if someone is using these gels or other forms of testosterone, they can expect that if they stop taking it, then their numbers will fall back to whatever they were before they started the replacement. There are certain people who cannot be on these medications, and so men who had a major cardiac event within the past 6 months, men who have high levels of hematocrit or high blood counts, because taking testosterone replacement therapy can increase your risk of stroke. And then for men who have high PSAs or untreated prostate or breast cancer. And then another caveat just to mention, it should not be used for men who are wishing to pursue having children, because fertility is affected by exogenous testosterone use, meaning testosterone that's coming from outside the body. And of course, it always boils down to lifestyle change. And so there are significant lifestyle changes that can improve your free testosterone levels. So physical activity, particularly in the form of resistance or weight training, high intensity interval training. Stress management is important. Increased levels of stress are associated with lower levels. Improving sleep quantity and quality. And then there's some mixed data about these ultra low carb or ketogenic diets. The real controversy is that it does increase your total testosterone, it appears, but at the same time, it appears to decrease the free testosterone. And so long term, it's unclear exactly what the implications are, but I just wanted to put that out there. And then anabolic steroid use, or the use of steroids for non-medical purposes, is very common, and unfortunately, it does have very negative effects on the heart. And so in America, about 3 to 4 million people are currently using anabolic steroids for non-medical purposes, and the effects on the heart are pretty drastic. And so you can have a decrease in the heart function, so the muscle can become weaker. You can have a thickening of the heart muscle, which will impede its function. It increases blood pressure, it worsens cholesterol levels, and it can promote blood clotting. And it's so significant, in fact, that patients who are using anabolic steroids are at a significantly increased risk of developing heart attack, heart failure, and stroke, with 3% of anabolic steroid users developing an MI at a young age. Numbers that we definitely hate to see. Lastly, I wanted to mention erectile dysfunction. So about 50% of men will develop erectile dysfunction in the course of their lives. There's different classes of erectile dysfunction, and so broadly speaking, there's what we call organic, or related to artery and vein disease. There's non-organic, which is related to anxiety or stress. There's drug-induced or alcohol-related, and there's hormone-induced, so anabolic steroid use or thyroid disease, for example. And related to coronary artery disease, it tends to be what we call a canary in the coal mine, meaning that it could be the first sign of having coronary disease. The reason for that is that disease of the arteries of the penis and of the heart, they share the same risk factors. And so hypertension, high cholesterol, tobacco use, diabetes, they'll affect both artery beds, but because the arteries in the nether regions are much smaller, they tend to develop signs of disease much sooner. And so men in their 40s, so young men who have erectile dysfunction, considered to have significantly increased risk of having coronary disease, and the number cited is a 50-fold increase. Among men who already have a diagnosis of coronary disease, 3 in 4 will also have a diagnosis of erectile dysfunction. And part of that is also going to be the fact that a lot of men with coronary disease are started on medications, which could decrease their libido and decrease, overall erection quality. So that includes medications like beta blockers, metoprolol is the most commonly used one, and diuretics like furosemide or hydrochlorothiazide. Regarding use of medications called PDE5 inhibitors, and so that's your sildenafil or Viagra or Cialis. So these are medications that were actually initially studied, what we call anti-anginals. So they were developed to see whether or not they decrease chest pain from coronary artery disease. They were really modest at that goal, but they had a very important side effect, is that men noticed that they were having improved erections. So that, of course, found a whole new market. Generally speaking, it is safe to use these medications if patients have no angina or mild angina. And we generally use a rule of thumb of what's called 4 metabolic equivalents, which is about 2 flights of stairs. And so if you're able to achieve 2 flights of stairs without chest pain or excessive difficulty breathing, then generally it's safe to use these medications even if you have coronary disease. Studies do show that there is some form of a benefit in taking these medications after a heart attack. And so in this study on the top right, they found that men who took these medications after a heart attack had reduced mortality and reduced heart failure hospitalization rates. But importantly, and this is a big caveat, a lot of men who have coronary disease are also taking medication called nitrates. Nitrates include medications like sublingual nitrates, which is a little tablet that goes under the tongue when people have anginal complaints, or long-acting nitrates like Emder or isosorbide. And so if you're taking those together, that does significantly increase risk of death, heart failure, and need for recurrent coronary stents. And so generally speaking, you don't want to be taking a nitrate at the same time. And so for medications like Viagra, we say 24 hours after Viagra use, you should not be using, or within the 24-hour time, you should not have both of these medications in your system. And for medications like Cialis, which are longer acting, you don't want to have it in your system for 48 hours. And the last kind of implication there is if you did use Viagra or Cialis or any of the other agents, and then you happen to have a heart attack, you have to let the team in the hospital know that you took these medications because that can impact what medications and therapies they're able to offer you in the emergent setting. And so with all that said, I just wanted to highlight our prevention cardiology clinic in Staten Island. So myself, Dr. Bahuria, and our nurse practitioner, Diana Pinkasova, we started this clinic with a goal of recognizing disease early, getting appropriate testing done, and counseling patients about what we can do to lower their risk of heart disease. If you're interested, you can always reach out to us. We have a phone number listed below, which you can always call to schedule an appointment. And at this point, I'm happy to answer any questions and to have a conversation.
Thank you so much, Dr. Nevelev. That was really amazing. Really, you hit on every major topic that Dr. Janos and I are always talking about with our patients, and that was such a great overview. And for those of you on the call that maybe see Dr. Janos and myself, we're so happy to have our counterparts with you and Dr. Bahuria and Diana in Staten Island. We feel so passionately about prevention, and unfortunately, a lot of times that patients are coming to us, there's either been a situation with them, whether that's an event or a new diagnosis, or perhaps with family members. And I did have a question for you that I'd love for you to address. When would you say a good time for patients to get a checkup, for a male patient specifically? A lot of times they're saying, well, women have menopause, or that's when women go to see cardiologists, or when you turn 40. But what would you say if there's a family history? Should everyone come in to see a cardiologist, not wait for symptoms? What would you guide our male patients for in that regard?
That's a really important point, because it's never too early, and it can be too late. So you want to be very mindful. Now, if you're already having symptoms, if you already have erectile dysfunction and you're only in your 30s or 40s, it may be already time to be seen. If you're having chest pain or shortness of breath with exertion, that's definitely a time that you may need to be evaluated. Family history is incredibly important. To me, it's one of the first things I ask, and one of the preeminent features of someone's history that make me pursue further testing. And so if you had a mom or a dad who had a heart attack at the age of 40 and you're 35, I'm worried, and we need to make sure that we're doing everything that we can to prevent you from having that same fate. If you have really significant risk factors, so if your cholesterol is incredibly high, if your LDL or so-called bad cholesterol is 220, you need to be seen by a specialist. These are things that could be easily treated, and long-term could significantly reduce your risk of having an event. So never too soon, can be too late. Definitely, partner with your primary care doctors. Make sure you're getting your risk factors assessed on a regular basis. And then if you carry more high-risk features, or if you already have symptoms, certainly should be seeing a cardiologist.
Absolutely. Yeah, no, such a good point. Dr. Janos and I say sometimes patients say, well, we didn't want to come and get checked out. We thought the doctor would tell us we have to start medications. We can still have a conversation when we're in a preventative mindset. Like you said, God forbid if there's been an event or something, then it's not a conversation. It's we have to get meds on board, and we have to optimize. So I think there's such an important time period there where we can really address a lot of the risk factors. And I think you touched on all of them so, so well. And, I love that you pointed out that you can have an unhealthy plant-based diet. I think a lot of times there's sort of this all or nothing mindset sometimes when it comes to healthy eating. And, we notice in our practice that a lot of our male patients tend to prioritize protein a lot. And a lot of those protein sources are animal products. So, how do you guide your male patients with that?
Yeah, protein is incredibly important. It helps maintain muscle mass. It's good for brain function. It's a key aspect of our diet. The source of protein does play a significant role in the risk for developing heart disease. And so the more you get from animal-based products, and specifically red meat and the like, the higher the risk of developing higher cholesterol and higher inflammation, and then thereby having higher risk of heart disease. So I definitely don't discourage people from having higher protein diets, but I tell people to be a little bit cautious about where they're getting their protein sources from.
Yeah, absolutely. I think quality, matters a lot because as you said, you need to prioritize really healthy plant-based foods as well. So I think that's so, so important. And do you have specific exercise recommendations that you give to patients? We have a lot of questions about, strength training versus cardio, how to balance that. What are you kind of guiding your patients with in that regard?
Yeah, it's a tough question. So I like to first say that there really are three forms of exercises that everyone should, broadly speaking. The first is the general, what we call cardio. So giving your heart an actual workload so that it pumps at a fast rate, support your circulatory system. So that's running, biking, swimming, what have you. The second is weight training. Having good muscle strength, especially as we age, becomes incredibly important. We have a natural decline in how much muscle mass we have, no matter what we're doing, but we can really significantly decrease that decline in muscle function by being physically. Doing a weight-based training is as important in my eyes as doing a, so to speak, cardio workout. And then lastly, you want to also have a component of mobility. So stretching, yoga, Pilates, what have you, something to get the joints limber and moving, even something as simple as Tai Chi. There's very strong evidence to show that that's overall good for heart function, body function, what have you. My overall recommendation is do what you enjoy. Like if you hate running, don't force yourself to become a runner. If you hate swimming, then don't go to the pool. Find something you enjoy, be it a sport or a game, something that gets you motivated, because that's going to be the thing you're most likely to stick with.
Mhm. Absolutely, 100%. It's what they're going to enjoy doing and stay consistent with. And, kind of circling back to the protein, sort of a little bit of a follow-up question. We do get a lot of questions about protein powders, supplements, workout types of supplements. Do you get a lot of questions from your male patients regarding that? And what do you think about the safety and the
Yeah,
efficacy?
certainly whey protein is not a problem at all. There's good data for whey protein being beneficial for cardiac health. A lot of these supplements have unknown additives, proprietary formulas that we don't know what it is. And I've had patients show me the labels and I can't interpret it. I actually don't know what
Right.
things are and I can't comment if it's good or not. And sometimes specifically stimulant use can be really harmful. And so a lot of these, pre-workouts, for example, they'll have tremendous amounts of caffeine. And that, if you already have underlying heart disease, getting that big of a load of caffeine may not be the best idea. If you have heart rhythm problems, they said 200 milligrams of caffeine in a single dose may not be the best idea.
Yeah.
Creatine and things like that, generally no issues with taking supplements like that. But really, it's the ones that have all these additives that I don't know what they are that I get worried about.
Agreed. Absolutely. And I think a lot of times people think that's more natural or for somehow that's more trustworthy to them than the prescription medications, so I think there can be a huge aspect of patient education that, as you said, they're not regulated. We just can't advise, and interactions with other prescription medications and things that they definitely need, is always a concern for us. And I don't know if you've gotten this question a lot more lately, but I think it used to be a lot more regarding hair loss that people were using topical things, Rogaine, but we've had a lot more of our patients saying, hey, my dermatologist recommended oral minoxidil. What do you guys think about that? We know obviously there's a blood pressure aspect of that. So are you having those questions more from your patients?
No, I feel like you have to really tease those questions out because most people aren't very open about using these medications or
It's true.
these gels. Um, you know, uh, certainly being on minoxidil does affect your blood pressure, and so that's a big consideration. And you definitely should let your cardiologist know if you're using either the topical or a minoxidil pill. I certainly don't have a problem with it. I don't think that, as long as you're monitoring your blood pressure, it's not a big concern. But sometimes, someone comes in and their blood pressure is totally off, and you're trying to figure out what's going on, and you realize they're actually using like a Rogaine type cream for their hair. So, be honest.
Yeah, yeah, absolutely. I think, in this day and age, there's these websites now, HIMS, right, where they can sort of go online and, get a lot of these drugs prescribed to them and things like that. So I think having that open line of communication is so, so important, to make sure that they're telling their doctor everything that's going on. They may not see that correlation. I think a lot, patients come to us saying, well, why did this happen? Or why did I get heart disease? And I think in your talk tonight, you did such a fantastic job of showing that it's so multifactorial. One of the biggest things I think that there's a misconception with is smoking, that people think about lung disease, they think about cancer, they really don't make that correlation with heart disease or with plaque buildup in the legs, anything like that. Do you find that there's still somewhat of a disconnect with that with your patients as well, or?
A disconnected, sorry, in regard to.
Yeah, for smoking sort of being a coronary heart disease risk, aspect, rather than just looking at it as lung cancer or lung issues.
Yeah, the very fortunate thing is that smoking rates have drastically decreased over the past few decades. Something like 60% of men or so were smokers in the 1960s, whereas now it's maybe closer to 20%, if not less. And teen smoking rates have been significantly dropping. In terms of cigarettes, of course, vaping has been a big problem.
Yes.
Taking it back to the point that I made before, there are a few things we can recommend outside of stopping smoking that can significantly, in a short period of time, decrease heart attack. Incredibly important. I always point that out to patients. If we stop smoking today, the risk of heart attack within the next 3 to 6 years will drop by half. Substantial drop. Smoking it doesn't just affect the arteries of the heart, it affects the lungs, it affects cancer risk, it can cause erectile dysfunction, you name it. And so it's important to focus on everything, but as a cardiologist, I'm a little bit biased, and I get to say that, stopping smoking now is a big thing you can do in the short term too.
Absolutely. Well, thank you so, so much, Dr. Nevelev. Seriously, this was such a wonderful talk. And I hope that I focused on all the questions that everyone had. If anybody in the audience has further questions, please don't hesitate to reach out to me. I'll make sure that you guys get connected. Such a wonderful resource to have you and your colleagues as far as prevention and just general cardiology. And thank you so, so much for taking the time and giving of your expertise this evening. We appreciate it so much. And yeah, it was a fantastic way to take a break. We are going to take a break for the remainder of the summer. There will be no lecture for July or August. We will be picking back up in September, but you really just ended on such a high note for us, and this was so informative. And thank you so much again.
Sure. Thanks everyone for joining. I think it's important that you took the time out of your evening. So
absolutely. Thanks so much, everyone. Bye for now, and we'll see you in September.